Thank you, everybody. Welcome to day 3 and the last leg of our 3-day conference. Appreciate you all being here. We're going to kick off now with the panel 3. Focus here is to discuss the impact of COVID-19 on regular health supply chains. Now, let me introduce you. We have 4 great panelists here. Not necessarily coming in that order of speaking, but Mr. Deo Kimera, he's the country director for USAID, GHSCS-2020 Ghana in Chemonics. Deo, I'll introduce each one of them a little bit briefly as we think about the sequence. Then we have Ms. Selsa Gaju. She's the Chief Operating Officer of Rwanda Medical Supply Limited. Abraham Akore, he's the CEO of Pyramid Pharma from Tanzania, as well as Amit Pakliwal, he's the CEO of PharmaRec from India. The way we are going to do this is each panelist will have a few, I'm asking them to do some opening remarks, and we will start with Ms. Selsa. Let me first briefly introduce Ms. Selsa, give a little bit more detail and then have the floor for her. And then we'll go with Mr. Deo Kimera and then move on to Abraham Akore and then Amit Pakliwal. The way these are structured, by the way, the panels for attendees, we have Selsa and Deo representing or giving the perspective of primarily public health supply chains, though obviously given their interaction in the respective countries, they also interact with the private sector. But they will, I've asked them to give a public sector perspective. And then Abraham, who's the CEO of Pyramid Pharma, will give the private sector perspective, not only from the context of Tanzania, but they operate across multiple countries. And following that, Amit will give a private sector perspective from India. So just a very brief introduction to Selsa. She's the Chief Operations Officer of Rwanda Medical Supply Limited. She started in this role earlier this year, but previously she's had extensive experience as the head of medical procurement and production division at Rwanda Biomedical Center. She has a fairly long vita, but I'm not going to take too much time to talk about that. Extensive experience and strong skills. Selsa, please go ahead. Oh, let me stop sharing.
So, good evening. My name is Chelsa Muzaire Gaju. I'm the Chief Operation Officer of Rwanda Medical Supply. My background, I have a bachelor degree in economics, master in procurement sustainable development. I've been working for procurement for more than 15 years now, and for 10 years of supply chain management. So my role in former medical MPPD, which was called Medical Procurement and Supply and Production Division. My role was to procure, to store, and distribute across the country, up to district pharmacy. Our supply chain management, our supply chain structure so we were the central store, but under an umbrella of all division treating about diseases in country, which called Rwanda Medical Supply, that have 16 divisions, among which we were part of. Then we were supplying up to district pharmacy. We have about 30 district pharmacies in the country. That's where our role was. So we were supposed to provide HIV, all program, drugs, pharmaceuticals, health products up to that level, so that the district pharmacy can take up to the health facility and hospitals. So we are quite big. We were an organization which was kind of parastatal under the umbrella of RBC, but currently since August, we move out from RBC by forming a company called Rwanda Medical Supply, which still have the same mission, but it's much bigger because we've been merging with district pharmacy to become one organization to be able to provide greater service by let's say, not following all rules of public procurement. I'm so sorry. By trying to be more efficient so that we can be even the response for the health sector. So maybe I can pause here. I'll move further with the discussion. I don't know if my introduction is well understood, or if you still have some. I think we can move because.
Yeah, that's okay, Celsa. That's good. I think we will come back with specific questions as we finish the introductory remarks from other people. Thank you. Yeah, please stay online. Yeah. Dev, may I ask you to switch on your video and give your introductory remarks?
My name is Deogratias Kimera. As introduced, the country director for USAID Global Supply Chain Procurement Supply Management in Ghana. Supply chain featured prominently among challenges presented by COVID-19 because of the anticipated disruptions at both supply and demand end. As you all know, that there was uncertainty about manufacturing capacity to meet the demand for both normal supply chain and for COVID-19 essential medicines. But also, I believe it's because of the high volume of PPEs, sanitizers, detergents, and other products that were coming to our list, which we were not routinely managing. Therefore, one of the major fears for supply chain, which I noted at the beginning, was the fear of unknown in terms of the volume of demand that is going to come to supply chain. In Ghana, how we addressed that was that we quickly supported the government to manage the donations that were being received from left and right by documenting them and making sure that data is captured for tracking and also volume monitoring, but also quickly adapted the WHO essential supplies forecasting tools, which was put on the public web, and adapted it to present some quantified expectations. And the biggest challenge was there were a lot of scenarios being presented. Worst case scenario where everybody, up to 10% of the population will be affected by COVID-19. And there were conservatives who expected to be less, and intermediary. So what we did to facilitate alleviating that fear of the unknown was to quantify for all three options, presenting the best scenario, worst scenario, and intermediary. That brought back the team to defined expectations of supply chain in terms of not only quantities, but also funding requirement, and also the volume of goods to be managed. So briefly, that's how we in Ghana here, kind of came face to face with the COVID-19 situation relating to supply chain.
Thank you, Deo. I appreciate that perspective. Let's move on to Abraham. And I think I should introduce Abraham. I forgot to introduce Deo more formally. I'm sorry about that, but just let me do that right now for folks who are just going back. Mr. Deo Kimera has 20 years international experience in health system strengthening, and has actually, even though he's currently the country director for USAID PSM program, in Ghana. He's had extensive experience in Botswana, Tanzania, Ghana, and Uganda as well. So he speaks in the Q&A session. We will try to tap into his subcontinental experience. Now, just a quick introduction to Mr. Abraham. Thank you for joining, Abraham. He's the managing director of Pyramid Healthcare Limited. It's a Mauritian holding company with operations in 11 African countries under the names of Pyramid Pharma Limited and Pacific Diagnostic Limited. He has led the company through rapid growth with a focus on after-sales service, positioning it as the largest diagnostic and imaging equipment distributor in many countries that the company operates mostly in East Africa. And now they're seeing a little bit of expansion in East and West Africa as well. He is also very passionate about affordable healthcare systems and utilizing public-private partnership. He serves currently as the CEO of Pyramid Pharma. Abraham, take it away.
Thank you very much, Ravi, for that introduction. So as you know, my name is Abraham. I'm based in Tanzania. And as Ravi said, that the company is Pyramid Healthcare, is an holding company based in Mauritius, but with operations in 11 countries under those two brand names. Pyramid Pharma, which mostly deals pharmaceuticals, laboratory equipment, consumables, medical supplies, and medical device. And Pacific, which is mostly dealing with imaging, critical care equipment, supplies, IT systems, and medical devices. The company focuses mostly on non-communicable disease, but we also have communicable disease, especially in laboratory space. And we operate both in East and West Africa, mostly almost in all English-speaking countries, with few Southern African countries. And like Ravi said, we have rapidly grown, and I would like to acknowledge that that growth has been led by investment from IFC and leapfrog investment. I will start with a general perspective and finish with supply chain challenges. Today, we are able to see closely the impact of COVID-19 has on our daily lives. So I would like to take 2 seconds to remember those who lost loved ones and the tremendous work that has been done by our frontline healthcare in any way you can. As you may have heard, most of African countries have not been severely affected by the disease itself. And I read somewhere today that in a continent of 1 billion, I think we have just reached 2 million patients. And we are faring much better in terms of mortality rates. While most countries began restriction on movement of people and social distancing, those restrictions currently have been eased. The lockdown has had severe effects on our daily lives, especially in Sub-Saharan. But measures have been taken for those who have been impacted severely. As you know, most of us do not have savings or social welfare system, and majority are living hand to mouth. And we're not very industrialized, and we mostly rely on inputs practically for everything, with exception of food in few countries. So the lockdown imposed mostly in US, Europe, India, let's say in Asia, who are the main suppliers of our finished goods, because we import technically 99% of all our healthcare goods have had severe supply, caused severe supply crisis. Majority of our subsidiaries and together with other companies that I know have not been able to keep supply commitments. And governments have diverted a lot of funds into stocking basic care supplies such as gloves, masks, and sanitizers. This tremendous demand for supplies has hiked up prices for a lot of people. For example, I would say that the price of face mask for pack of 50 has gone from $10 to $60 on wholesale in Tanzania, for example. And for sanitizer of half 100 mils has gone from $0.5 to $6. In some days we had to queue for it. The prices for disposable gowns has gone from $1.50 to $3, and with no availability. And in most cases, we have had to overstock for many of procedures which were done normally, like knee procedures, cardiac procedures, which were suspended. We have had to overstock because we don't know when these supplies are coming from US and China. We don't know when they will open, so we have had to overstock. And for the fear of infection, people have reduced the visit to hospitals and have resorted to either self-medication for minor ailments than going to a hospital. We have had the number of patients visiting hospitals coming down severely. I know some hospitals which had income of monthly revenue of about $2.5 million. They had gone down to $500,000 at a time of crisis here in Tanzania, for example. So the hospitals' income have relatively fallen. So they're not able to pay suppliers. They're not able to order. They're not able to pay their employee allowances. Neither they are able to pay for the equipment. So this loss of regular income has resulted in many employees resorting to pay cuts, sometimes up to 50% from the few hospitals that I know. So all these measures have had major effect in quality of care that the hospitals are being able to provide. Because of these factors, supply chain is also affected. So since the hospital are not able to pay on time, we're not able to order on time. Banks have also stopped providing credit. And in many of African countries, as you know, for example, in Nigeria, Tanzania, there is foreign exchange restrictions. And there is overall drop in cargo volumes coming especially to Africa. So this has caused excessive delays with all the supplies that we're trying to get. For example, we ordered some goods with lead time of 2 months, which turned out to be 7 months. And in many countries where there are no freighters, so large volume cargos, which were supposed to come by air. For example, for Nigeria, sometimes we have had to ship to Ghana and there is a border closure because of problems there. In Tanzania, there are no large cargos coming, so we have to transshipment via Kenya. So the supply chain has severely been disrupted. I'll stop there for now.
Thanks a lot, Abraham. That's a pretty comprehensive view of some of the challenges that you have faced. We'll get back to specific questions. Let's move on to our final panelist, Amit Paklewal. Amit is from India. I mean, he's right now in India. He runs a company called PharmaRack. He's the co-founder and CEO. It is India's largest B2B technology platform, digitizing the entire pharmaceutical ecosystem to solve access and availability issues in healthcare products. He will talk a little bit about the scale of the platform in terms of the number of distributors, etc. Previously, he was head of Asia Pacific for IQVIA, which is a information data analytics kind of company in the pharmaceutical space. So I really wanted Amit to be here and appreciate that he's joining because it's actually quite late in India. And I know that he's an early morning person. So I hope you have caffeinated enough to stay awake. So to provide a perspective of not a two different, one is Abraham, he spoke about the private sector perspective. So Amit will, would also provide more of a pharma private sector perspective. But India, and Amit, talk a little bit about how India's health landscape is different than the African subcontinent as well. Okay,
Sure.
Amit, over to you.
Thanks. So thanks, Ravi, for inviting me, and pleasure to be here. What I'll do is, as you rightly said, the landscape is slightly complex. I've got a few slides to present, and I'll walk them through so that people get a context on some of the complexities there. So I think I'm able to do a share screen. Yeah. Is everyone able to see my screen? Ravi, you can see my screen?
Yeah, I can see.
Okay. So just to give you some perspective to everyone, India as a pharmaceutical market is in the top 10 pharma markets in the world. It's still growing double digits, and it continues to outgrow most of the global markets purely because of access and number of patients and people are there. One of the interesting parts, and which is a pretty sad part, is India has one of the lowest priced medicines in the market, however, has one of the highest supply chain margins that exist, right from the time from manufacturer sends the product to the time it actually gets to the patient. Anywhere between 30 to 35% margins exist. And it's even more worrying because 80 to 85% of the market is generics, right? And a significant portion of that branded generics. And one of the fundamental issues why a lot of this exists is predominantly because each component of the supply chain or the stakeholders are not connected. So there are lots and lots of intermediaries, from thousands of manufacturers to 65, 70,000 distributors to 800 to 900,000 pharmacies, over 1 million doctors, and none of these are actually connected. Lots of manual intervention, lots of people actually going in, collecting orders, short books, and which is very similar to a lot of the African markets, emerging markets. And so one of the key things for us was, as a vision or a mission, was how do we really digitize and connect the whole supply chain, right from the manufacturer to the end, at least the pharmacy, so that we are able to provide information symmetry and take out some of these inefficiencies that exist. To add to the complexity, one of the challenges that exists was also that there are no technology systems that are existing across these, right? So pharma companies may have, or the OEMs, or the suppliers may have SAP or some of the state-of-the-art integration systems, but as soon as you go from the the pharma company's warehouse to the distributor, you're talking about very, very basic tally or even DOS-based systems. And then you go down to the pharmacies, more than half the pharmacies don't even have a point of sale. So one of the challenges that always exists is how do you digitize and connect this? So we created some applications which actually sit on top of the distributor's inventory, which gives us access to the live inventory of these distributors. And it allows the distributor salespeople to carry the inventory in their hand when they're going out in the market to collect orders from the pharmacies. That's the first thing we did. And the second thing we did then was we also created an application which sits at the pharmacy. As more and more distributors started coming on board, more pharmacies came on board because now they could use the platform to order directly. They didn't need to wait for a sales rep or someone to come in. So just kind of giving you a perspective, as Abraham also spoke about, high capital requirements, loss of sales, no visibility, similar issues that happen in hospital, obviously also happen in the retail arena, and even more fragmented, right? And a lot of dependence on manual interface, people, and so on. The other part around this is because the original manufacturer, the companies are dependent on, or their sales are measured on primary sales that are sold into the distribution system, there is a lot of stock dumping that happens, which means there is a huge amount of inventory buildup, anywhere between 20 to 30% excess inventory that's sitting in the system at the distributor at any given point in time, but there is no visibility on the offtake that happens at the pharmacy and who's the customer buying it, is it actually happening or not? So that also locks a lot of value into the system. And then last but not the least, one of the basic issues and the crux of the problem that exists is that when you look at some of these systems, and we saw that during COVID, and Ravi, you and I spoke about it, was in India, you see some of the data that's coming out, we're seeing COVID cases rising daily, right? One of the problems is that people are rushing to the pharmacies to procure medicines. But fundamentally, the problem in the absence of any of these systems is a pharmacy does not know which distributor to go to and where the supplier is sitting for that particular product. So a classic example, which is used about hand sanitizers, gloves, PPE kits, to oximeters, and then obviously, when hydroxychloroquine became very popular, and then dexamethasone became popular, we saw a huge surge in demand that picked up. But then there were only a few distributors who had a huge amount of stock. Now, because we had the understanding and the visibility of where the stock was sitting, we were able to really move that around and help some of the pharmacies get that access. Otherwise, in typical days, you would have these guys sitting on that stock, and that liquidation is not happening, right? And then the prices go up. And this is just a classic case in a small way that we've seen some of these issues have just skyrocketed and become a huge problem. Part of that, what we've been able to do is also work with the state governments in India in two of the last states. I stay in Mumbai, so Maharashtra, which is one of the last states, and unfortunately, the state where the highest amount of COVID cases are coming up, and another neighboring state. We are providing the government access to some of the daily data on inventory of some of the essential medicines and stocks, which are sitting and which distributor is actually holding it, especially during these COVID times, so that as and when the need arises, they're able to reach out and connect that. So I've just provided some illustrations around on the left-hand side, how the reality works in terms of how the ordering process happens from a pharmacy to distributor. One pharmacy works with 8 to 10 distributors at any given point in time, and everything is manually driven, which has lots of errors. With PharmaRack coming in, we have close to 75,000 pharmacies who use our platform to order directly, and we have access to close to 200,000 pharmacies that we can reach out to in India, where we can connect them directly to the suppliers, which means a lot of this manual interface errors can go out. Same happens in the time of a distributor. When the distributor salesmen go to the pharmacies to collect order, now the pharmacy can place order directly, or the distributor can get connected. And last but not the least, we've also connected now the manufacturers with the distributors, so that now it's starting to create a whole pipe right from the company to the end retailer. So it's a lot of work, as you can appreciate. Lots and lots of individual, small, medium enterprises, lack of IT systems, no visibility. So in the last few years, we've been fortunate enough to build all these solutions, right from connecting them to be able to do delivery. We spoke about payments and actually some of that. We process close to about $1 billion worth of transactions annually on our platform, which is about 8 or 10% of the entire pharma market through our platform. I already spoke about the distributors and pharmacies and so, and that's been very helpful because as the scale is going up, it's allowing us to play a larger role in shaping some of the decisions that happen and at least providing the next level of visibility that's required in the market. So I'll pause there, Ravi, for questions.
Yeah, thanks a lot, Amit. Let's get back and let's have all the panelists switch on their video if you may. And let me get back to Dev, and Celsa both, but maybe start with Dev. You've seen now both Abraham and Amit, of course, Amit is in a different context, talk about the private sector and what they can do. And I would like you to speak a little bit about, how you see, especially in a pandemic, the role of a private sector in helping you respond more quickly, perhaps, what do you see has worked and, what could be done?
Thank you, Ravi. So I didn't I didn't share about my experience in,
please do.
management of COVID. So we at that time we were medical procurement and supply division. So we start process of procurement in January. After the global warming of the coronavirus, so we started preparing in terms of testing, in terms of equipment, getting ventilators, oximeters, and all other equipment, and then PPP. The way we had a stock from management of COVID, of Ebola, that help us in that period to understand how can we approach the quantification of COVID. At that time, it was really, we struggled actually to get technical specification. We came up to understand that there were different PPPs, that Ebola, it was different to, PPP for Ebola was different to COVID PPP. So we tried to do the quantification, and we put ourselves in a scenario of 50,000 patients. Then we did the quantification, then we start contacting the supplier. Our first cases was on 6 March. So from January to March, I can say that we had quite a good time to get prepared. So our process, let me come back on the process of procurement, because we had a heavy procurement process and it was not yet a pandemic. The way we did it, we went by contacting suppliers one by one. This was our first time to do that kind of process because it was not captured in our manuals. And we went by asking what are the stock on hand that we have first in country. That was our first strategy, to identify what can we get from our local suppliers in terms of ICU beds, in terms of ventilators, in terms of patient monitors, and how, and then it was a collective initiative and really driven by multi-sectors. It was a multi-sectors exercise, but I was in charge of supplying. Then, but the determination of COVID center. So in January already, there were determination of we call it isolation centers. So we went and we took like, it was 15 hotels where we were supposed to take our visitors. They were supposed to be tested at the level of airports already. And we had to supply there VTM and VTM so that we can take noise and nasal tests for the PCR at our national lab. So the national lab had also on their side to develop an algorithm on how they can come up with the test of COVID. So they learned it at that time, and it took them, I think it took them like 2 weeks. They had trainings, we had support of Germany, China. So they came here with the VTM and some PCR machine. We use Roche and Abbott machine to determine to do the test of COVID. So at that time, it was taking it was 14 days of quarantine. So we had to supply everything that our people needed. Being medical or non-medical means that we end up by even buying some slippers, everything that they were needed in terms of surviving, because they were not able to go out. And this was taken in charge by the government. from January to March, that's how we operate, because at that time we had just to provide for the isolation center. Then after, we came up with the PPEs. The way we bought the PPEs, we passed through our all embassies, because at that time also, remember that we had the lockdown, and most of the products of PPEs were blocked by the countries, because they didn't want to allow their people to sell. So all our contracts where we had masks, where we had hand sanitizer, our supplier were not able to supply. So our government took initiative. We had some small factory here, they took over. They started producing. They couldn't get enough alcohol, so they helped them to get enough alcohol to start producing. It was really stressful. So we went, I think the lockdown started on 2020. It was 2 weeks after. Then we had a complete lockdown for 2 months. That was the stressful period for us, because we had to deal with the supplier that are already locked. So our team, good enough, we had a good team of COVID there. We had one team, it was a whole management for the country. We had people working in IT, collecting data, any entry that we had in country, they were following up. And so I will only talk about the supply of COVID. So at that time, my whole time was in airports, waiting for shipment, waiting for the flight, landing, taking the goods, coming here, counting, reporting. So that was really our aim task. So the procurement was done through embassies, and they managed to get all PPEs. The way we did it is we send them the list. We sell to all our embassies the list. So they were trying to take the stock where they can find them and share with the costs of each PPEs, so that we can get we can give them the go ahead. So that's how we manage.
Yeah.
And then
Celsa, that's great. If I may ask you just to hold off, we'll come back to the rest of the questions. So this is wonderful.
Yes.
I think two things that I pick up really in a severe disruption like this, reach out to your embassy, so your governmental relationship, but also the interesting stuff. What I hear is that when, there is distress in the production, government stepping in to take over production in the factory to ensure supplies.
Absolutely.
Right.
The
So
government stepped in. We had some cascaded meeting. So we had meeting at higher level. That's why our role was to provide what we need.
Yeah.
Then we had our bosses talk to the Prime Minister, talk to the Minister of Finance. They had to release money so that we can get supplies.
Yeah.
So, but we had also to do that process of verification of pricing, which was not really evident.
yes.
Because a mask that was costing us like $2 for a box of 50 came up with $6. So at first glance, we were reluctant to give a go ahead, but then after they told us that, guys, they are going to stop everything. So you need to decide very quickly and give us the. So we had only some hours of decision of checking the price quickly, and then go ahead and tell them that this is okay, you can ship them. So another thing is about quality. The quality was not really, we couldn't even measure how we are going to do with the quality, because we had to send one day, several times to get PPEs in country, because the airlines were not working, cargo were not working, and we had to do some extra efforts. We even have some cases where we had to go and take also some technicians for our machine to do the maintenance during the lockdown. So it was a period that we all learned about that one, and we understand that our procurement process does not capture about anything about we don't have anything about process of coping with the pandemic.
Yeah.
Nothing.
Mm-hmm.
Because when we are talking about single source, you need to justify, you need to, but in terms of pandemic, we were like, then we wrote a memo saying that this period, this is how we are going to observe only the principles of procurement, transparency, economy, but we can't do the whole process. But that gives us also a homework after to think on how we can handle future pandemic.
That's great, Celsa. Celsa, we'll come back to that in terms of your core learnings that you're getting into. Just hold off on that. Let's also hear from Dev. You want to kind of elaborate on some of the things that you guys did? You're muted, Dev.
Thanks very much. Are you able to see my slide, please?
Yes, yes.
Okay, thank you very much for the opportunity to discuss. As I mentioned earlier, that I'm working with PSM. We cover the end-to-end supply chain, as you might see in the above diagram, whereby COVID disrupted the supply side, but also it disrupted on the demand side on the patient, as they could not go to the facilities. For purposes of this discussion and answering your question about the private sector, we put a lot of emphasis on in-country supply chain from where I work, while communicating to the upstream with our global team. And from private sector perspective, we found that the private sector was quite efficient and very responsive when it came to distribution. So government had initially mobilized all resources available in terms of trucks within the government sector, but immediately we collaborated and coordinated with government and engaged them to mobilize resources not only for procurement, but for the entire supply chain. And once the resources were mobilized, with the donor support, we were able to subcontract the private sector, and they were able to deliver commodities efficiently. So one area where the private sector can do a lot is distribution. And also we managed to divert the focus from investing from warehousing to distribution networks, because commodities were coming in huge volume and needed, but if we focus on warehousing them, they wouldn't get to where they are needed most. So we focused investing resources in distribution using warehouse, which was available more as a transit point. The other issue which my colleagues also from the pharmaceutical sector talked about was the issue of data. In the country, we have the LMIS, and fortunately, we were rolling it out and it was scalable, and we managed to use it for COVID-19. But in terms of maintaining the regular supply chain, I think this model here, which I'm indicating here, it is important that there is a end-to-end visibility. For now, as PSM, we have connectivity between the in-country data and the automated requisition tracking management information system. And also we have, visibility within WAMBO. But it will be good if in the future, now I'm talking about solutions because of time, that if we have connectivity with the vendors, with the pharmaceutical companies, so that we know what commodities are available where. Because where we made a lot of difference from PSM perspective was where we analyzed the available the commodities at service delivery point for regular supply chains, for malaria, for HIV, for family planning, and be able to demonstrate them in terms of month of stock available, share those with the global team, which was able to cross-check with manufacturing capacity, and then were able to advise government on where we have a risk and where we don't have a risk. So we are also able to accelerate differentiated service delivery, whereby because we knew from the data analysis how many months of stock we have, we are able to accelerate the multi-month dispensing for HIV and make sure that clients don't need to visit the facilities frequently and therefore minimize the infection. But at the same time, we were able to accelerate implementation of direct delivery of commodities to some clients through models of hope, through civil society organization. So we believe that going forward, we should look at a situation where there will be another COVID or another virus which will limit movement, and look at our last mile from the health facility and up to the client who's supposed to receive the commodities. So from that aspect of the private sector, we see that investment into digital technology or infrastructure would be very, very important, because in most of the upcountry facilities, we don't have good networks. Therefore, we have these solutions like I'm demonstrating here, but when you go low in the upcountry, you cannot have the internet connectivity to run these solutions. So private sector investment into digital technology throughout the countries where we work would also be of added advantage. In the interest of time, I'll stop here for now. Thanks.
Thanks a lot, Dave, for those excellent comments, and also connecting into what a future role for technology might be in connecting the supply chains. Abraham, now that you've heard from our public sector friends, say a little bit more about how you saw this, because in your opening remarks, you said there was a huge disruption in supplies, and but in the countries that you operate, healthcare is dominantly provided by the public sector. So we'd appreciate hearing from you about, what do you see as ways to do a, better coordination between private and public sector. They've talked about perhaps leveraging private sector for downstream distribution, which is something that your company actually does. But at the same time, we heard from Celsa that upstream, given the huge shortage and inability to get, the government had to step in and leverage their connections with the embassies, et cetera, to secure supplies. So given that situation, especially in a pandemic thing, how do you see a public-private partnership playing out? Do we have Abraham, or did we lose him?
No, I don't think he's there, Robbie. I think he's dropped off.
I don't know why. Okay, so anybody else wants to respond to that question? I know, Amit, your situation is slightly different, even though you mentioned that, your platform was then being used to provide visibility to the state governments.
Yeah, so I think if you look at from a public-private partnership point of view, whether you look at India or any of the other markets, because historically I've done work in some of the markets which are public sector driven as well. I think one of the challenges is there is always a gap and a lack of appreciation between what public sector brings and what private sector brings to the table. And although we speak a lot about the public-private partnerships, one of the fundamental concerns always is around private sector is for profit, and the intents are obviously skewed towards trying to make more money out of things, versus public sector is always about getting everything free. I think that whole commercial financial thing is one of the key components, at least in my experience, which has prevented, which is where I think a lot of the neutrality of different bodies comes in to help drive it. The second thing is, if you look at COVID specifically, even in markets like India and others, I think there is an openness now because of the disruption that has happened, that both the parties are starting to talk and are open to look at collaborations. We're seeing increasing amount, even in market like India, government is inviting startups, private sector companies to come in and support, either for manufacturing of PPE kits to equipment and stuff, or the private sector is going to public sector and saying, listen, we are keen, we have this infrastructure, how can we help and support? So I think at least what we're starting to see is this is a great opportunity to try and converge this and use this opportunity to create a more harmonious way that the public and private sector can go hand in hand. Because the pandemic has also created a common problem, right? Which is not looking at whether it's a public or a private sector problem. It's a problem for everyone. So at least from our point of view and what I've seen is there is an openness. And I do think and believe that this will drive a lot more, I think, openness in doing things forward. I just think Abraham's just joined.
Yeah, Abraham is just back. Sorry, we lost you there, Abraham. So the question I was asking, following the remarks from Celsa and Deo, was this idea that there is potential for private sector participation. I mean, what you said in your remarks was that you had challenge securing supplies because of shortages. And they basically outlined how private sector was very helpful given their agility to in the distribution end of the supply chain. At the same time, Celsa was talking about when you have huge shortages, maybe government can actually step in using their connections through embassies, et cetera, to secure supplies. So given that, I think we lost him again. So he's having some connection troubles. So he may come back again. But Celsa, could you say a little bit, are you there, Abraham?
No, I wanted just to make a comment on the PPP.
Yes, go ahead.
The comment I wanted to make is that one area where public-private partnership can happen is mainly in the local production, because we have seen that relying on production outside the continent presents challenges when we have global diseases like COVID-19, and we know there are many more viruses that might come up. But investing in that infrastructure has a chance of creating redundancy because the market is not yet big enough to be able to enable West Africa, East Africa, Southern Africa have manufacturing plants. So I see opportunity where public-private partnership can come in, where the multinationals who are already manufacturing, who have the technology, can collaborate with the public sector so that the public sector can invest in some degree of redundancy, but for protection of the communities that they serve. So I see an opportunity for PPP in a local production, not by each country, but probably regional blocks.
Yeah. Celsa, would you like to add something to that in terms of this idea of encouraging regional production and the role of private sector there?
Yes. Actually, I think it shows us how much we are very vulnerable in terms of getting the product in country, and we need really to build partnership to get the product in country and start producing not only what even other medicine, because it's even a burden to the country when we need to get everything from abroad. And also what I wanted to recognize as well is some donation that we got from Jack Ma, from big philanthropists. And I think they also play a big role in terms of shipping some numbers of PPEs. But definitely in terms of sustainability, we need to have some factory in country, try to even, I think the shipping mode is just stressful. Being in shipping mode for more than 10 years, for me, I think we need to move on the other side and try to get some product in country, develop partnership with manufacturers so that they can start creating lines of production in country.
Right, that's wonderful. I think I'm exchanging WhatsApp messages with Abraham. There is network attack. He's not able to connect through internet, so we'll see. Dave, I wanted to get back to you. You mentioned briefly about this differentiated service delivery idea. So what beyond part of the strategy to respond to pandemic also, because this hesitation of, I think Abraham was talking about, for people to come to clinics and hospitals not having. So clearly, you want to reduce traffic because people are hesitant, etc. So tell us a little bit more about the differentiated service delivery idea.
I think we leverage what was going on already under HIV, whereby HIV program had already initiated the differentiated service delivery, but the uptake was sluggish, very slow because it was optional. So when COVID-19 hit in, it was an opportunity to look at it as a model that can actually reach the last mile, where the last mile is no longer the health facility, but the client who deserves treatment. So month-to-month dispensing, for example, for HIV, given that the commodities is a chronic disease and the commodities are taken for a longer period, helped to reduce the frequency. But also we can look at it from other angle. I'm reading about a lot of increase in unwanted pregnancies during COVID period. We are still documenting, we are yet to get data whether that is attributable to limited supply of family planning commodities, but it might have been also due to the fear of going to facilities when you are not sick because you just need your family planning commodities. And therefore, considering models that are able to reach to communities where they are without them moving to the health facilities would be very useful in such circumstances whereby we can avoid the consequences of unwanted pregnancies on the economy and on many other factors, school-going children and the rest. So that mechanism can be expanded to even also include public-private partnership, because the private sector invests where there is demand. If there is a demand within the communities, the private sector is likely to invest in those models that reach the communities. So it can be an opportunity also where public-private partnership can be extended and be able to reach as many communities directly as possible, so that we don't focus our health solutions at a health center, but more in the communities where services are required.
Yeah, okay. You can hear me, right? Were you able to hear Dave?
Yes, I can hear you.
Right, so I'm trying to project him. He's on WhatsApp. I don't know if you can see him. We are trying this idea. So maybe in the time that we have a little bit, Abraham, if you could say something about, because Dave has talked about how they leverage private sector for downstream distribution,
Yes.
and private sector is very agile. At the same time, you talked about upstream having difficulty securing supplies where the government potentially could step in and leverage their connections with embassies, etc. So how do you see this public-private partnership playing out, though, given all the challenges you have articulated?
So the first thing I would say that even before we do this private-public partnership, I think there's a lot of distrust in the system with the private sector. So, and we have not done much during this crisis to assist. There was unnecessary price hiking. And I think during pandemic, it's not a time to profit. When there is a crisis, we have to get together to solve the problem. And Leo was very correctly to say that we are very agile in distribution downstream. But upstream, I think one thing that we have, which I saw, sometimes the demand was being hiked government not having a very coordinated efforts. So you have the government floating one supply to 20 wholesalers or international buyers. And then the same goes to one manufacturer thinking that the demand is for 2,000. And then the price goes up tremendously. There are many established partners who were able to coordinate and talk to suppliers in order to get better prices. But this mechanism or this coordination between government and private was not there. And I can say this in many countries that we operate. There was no coordination at all. So one thing that we could have done better was to sit on the table between private and government, and what do you have, what do we have, and especially during this period, one thing that we could have done better was to restrict the supply of critical items like face masks, sanitizers, and provide it to front care workers before anybody was using it, because we have our doctors having no mask, and then we have children playing with masks on outside, which was very bad use of resources. So I would say there has to be a mechanism to engage better upfront, whether they want downstream or upstream supplies, but there was no coordination at all.
Thank you, Abraham. Maybe Celsa or Deo, you want to respond to that in terms of the better coordination, perhaps?
Yes, allow me to respond with the one slide here, which I'll show you that what worked well in Ghana actually is a summary of those factors. And in fact, I'm glad that you highlighted coordination, because it might have been a big issue in some countries, but in Ghana, coordination worked out well. And when the supply chain came on board, we were able to articulate that what else is required in order to make sure that the commodities reach where they are needed. So government leadership.
If you may mute, yeah, okay, sorry.
Are you able to hear me?
Yeah, go ahead.
Okay, so government leadership as part of the success factor is critical, and we saw that happen here. Coordination mechanisms, making sure that all stakeholders on board, including the private sector, I've already mentioned. Funding was critical, because without funds, even the private sector wouldn't come on board beyond donation, which they made. So more funds mobilization was able to occur. Private sector engagement is quite critical, and I believe that there is a symbiotic relationship between private and public sector, whereby there is mutual benefit when government engages the private sector, because at the beginning, the private sector was able to make contributions of commodities like PPE, sanitizer that were needed. And in return, when the government got funding for delivering the commodities, they were able to engage the private sector to deliver commodities to the end user. So it's kind of a symbiotic relationship. In terms of your previous question about manufacturing, I think the private sector demonstrated again responsiveness when they were able to produce the masks locally. In the beginning, N195, which were the masks available, and the medical masks, were getting all finished up by the community. Once the local industry picked them up and was able to produce, the scarcity for masks, was resolved. So the private sector is quite creative and comes up with solutions for every problem. Once there is that partnership and the required funding can be mobilized, coordinated by government leadership, we are able to see results. Of course, I've already talked about the other two, data gathering and differentiated service delivery. So I believe all those factors are quite important.
Yeah, that's excellent. Celsa, you wanted to add something? Celsa, are you there?
works already. And so we didn't have any problem in terms of structuring our supply chain because it's already established. As we are the central store of medical, so we are actually in charge of supplying to all health facilities through our 30 point of distribution. So we were able to ship everything that we are not really facing a challenge in terms of shipping goods, and our main challenge was how to get them from abroad. And that's how I appreciate the proposal of partnering with private sector, as long as the cost is also going with that. The only challenge is about getting the right cost when you are in partnership with PPEs. So, yes.
Wonderful.
For me, it goes more in terms of production. We need really to get production and get the transfer of technology in country and get the product in country.
So I didn't, it looks like I was following the Q&A box. Most of the questions our panelists answered via text. So there were many good questions, but many questions got answered via text. So I didn't kind of pull up those questions to ask you. But maybe in the, we're almost out of time, but just take 10 seconds each to say any closing remarks regarding this post-pandemic. If we go forward, what would you like to see? What would you like to see post-pandemic? So Abraham, maybe we'll start with you. Post-pandemic, what would you like to see?
I think better coordination in advance on how to handle any crisis situation. Let it be fire, because I could tell you when it's time, when there is fire or terrorist attack in most of the countries, you'll see the private sector giving out ambulances, people are donating, so things are much more structured when there is a problem. So I think better coordination for pandemic time, so and lay out each part what they are expected to do.
Yeah.
Thank you.
Wonderful. Thank you. Celsa, 10 seconds.
Hello.
Yeah, in 10 seconds, any closing thoughts?
So I'll be interested to follow up on any initiative that goes. I like the presentation of pyramids. I would like to get in touch with him to understand how we can get all these information because I have a lot of questions, but it will be a kind of a side meeting. But what I wanted to follow up is only the initiative that we have, that you may have in terms of investment in developing countries to move together on those kind of initiatives. But I would also explore the option of being a membership of Pyramid software to get in touch with distributors and manufacturers in India, because it's quite challenging in India. This is another world where you can get good and bad products. And we need to understand which kind of agencies are providing the right certificates and to really reduce the risk to zero to get the bad product in country. So up to now, it's not yet clear on the strategy that you need to get from India, except we tried to get in touch with Mylan, Hetero, all these big companies that are supplying already some program product like ARVs and TB, like MyCleod as well. But in India, you have a world of pharmaceuticals factories. So
we are interested to get the good ones.
Definitely, Salsa,
That's
we
my
will arrange.
request for pyramid.
Yeah. Happy to arrange a separate conference call among all the folks here, and we can do that separately.
And also, sorry, and also all initiative, IT initiative that connects all pharmaceuticals companies.
Yeah.
In an IT solution.
Yeah, definitely. We'll set up. We'll set up a call, Salsa, and we will brainstorm some of these things. Amit, you want to add something?
Just a quick one. I think for me, the key standout is technology and a connectivity of the entire ecosystem. I think that's the only enabler which will take out a lot of these inefficiencies, cost issues, pricing, all the things that we talk about fundamentally are there because healthcare is not connected. It's fragmented, it's broken. And the different parts of the ecosystem, whether it's the US or India or Africa, we have the same problem, right? In different levels. Yeah. So in an ideal world, manufacturer, physician, pharmacy, hospital, labs, if you've got ecosystems connected, I think that's when the patient benefits would happen. So to me, that's the holy grail to get to, and as a company as well.
Great, thank you so much. Dale, last 10 seconds. We are running out of time. We have to, yeah.
I'd recommend building on the collaborative platforms that have been established between the private sector, public sector, manufacturers, communities during the COVID pandemic to benefit regular supply chains so that we don't dismantle them after COVID, but we build on them to sustain regular supply chain and make them work more efficiently.
Wonderful. On that great note, thank you so much, all the panelists. Appreciate it. I know it's, especially for the folks in eastern part of Africa and India, it's quite late. Really appreciate you staying up and having this great discussion.